Bueno, muy buenos días a todos. Bienvenidos y bienvenidas
Good
a la
morning
sesión
with
de hoy.
everyone. Welcome to
Bueno,
today's session. My name is
soy el
Christian
representante
Moralo.
de
I
la
am the
Organización para la
representative of
Salud de
the
la OMS
Pan
en
American
Madrid.
Organization
Durante la próxima hora
of
y media
Health. Throughout the
tendré el gusto
following
de
hour and a
acompañarlos
half,
como moderador de este evento.
I will be the moderator
Este
of this
episodio
event. The
forma parte de una
first part of
serie dedicada a la
today
atención
is a
primaria de
part
salud
of a series
que está
dedicated to
centrada
the
en el
primary
informe
attention of
regional
health
titulado
that is focused on the
Avances hacia
regional
la salud
report
basada en la
called
región de las
A
Américas,
Progress in the Region of
abordar
the
las necesidades
Americas to be able to
de
work
atención de salud,
on the
las brechas en
parts
la
of health
cobertura y
education
la
gaps in
falta de
coverage
cobertura
and also the
financiera
lack of
mediante la
financial
atención primaria
coverage
de salud,
in
publicado
reference
por la
to
OMS.
this
Contamos con un
published.
grupo de distinguidos
We
panelistas
have
y queremos
a
agradecer
list of
especialmente por haberse
distinguished
acercado
panelists
este
that we
día
would like
en esta
to
oportunidad y a
appreciate
quienes
for them
iremos
being here today,
presentando
and we'll
oportunamente.
be presenting them
Ahora bien,
when
antes de
time
empezar, quisiera
comes.
señalar algunos
Before
aspectos
beginning, I would
logísticos.
like to talk about some logistic
Estamos
aspects.
ofreciendo interpretación
We are
simultánea
offering
en inglés,
simultaneous
español,
interpretation in
portugués y
English, Spanish,
francés, de los
Portuguese,
cuatro
and
idiomas de la
French in the
organización.
four
Por
languages of the
favor, elija el
organization.
idioma de su
Please choose the
preferencia
language of your preference
en la parte de las
in the
herramientas
bottom part
de
of the
presentación.
tools.
Para escoger el idioma deberán presionar el botón en forma de globo que se
Here
encuentra en
in
la parte
reference
inferior
to
de
being
su
able to have
pantalla.
interpretation, you need to
Contamos
put
también
click
con
on
interpretación
the
simultánea al
globe
sistema de
on
signos
the
que se
bottom.
encuentra
And we also
presente
have a
en pantalla
sign
durante
language
toda esta actividad.
interpretation that you're able
Por
to
favor,
see in the
tengan
screen.
cuenta que pueden
Please,
enviar sus comentarios y
we hope
preguntas
for
en
you to
cualquier
be able to any
momento
comments
dentro
or
del
suggestions at any
esta
moment
actividad.
within the seminar.
Recordamos también, sobre
We would
todo a
also
nuestros
like to
viajeros
remind you,
y a la
especially to our
organización, que
panelists,
mantendremos
that
los
we
micrófonos
will
apagados para
have
facilitar
our
el desarrollo de la
microphones
actividad.
off to
Y
be
por
able to
último,
help the
le pedimos
development
también a los panelistas y
of
panelistas
the
que
event.
hagan un
And finally, we
esfuerzo
would
por
like
no
to
hablar
ask
muy rápido
everyone
para
to make an
facilitar
effort to
el
not
trabajo de
speak
interpretación
quickly
simultánea y, por
or
supuesto, no
rapidly,
someterse
just
al
to
tiempo
help in the
de
interpretation. And
amplio
please let's adjust to the times
concedido
that
por los
have been
organizadores.
given by the
Ahora,
organizers.
como moderador,
Now,
tengo
as a
el
moderator,
privilegio, el
I
privilegio
have
de
the
dar inicio a este
privilege
seminario
of
virtual.
giving the opening
Quisiera
words to this
señalar
virtual seminar.
que
And
este
I would
informe,
also like
publicado el
to
pasado diciembre en el Día
state
de la Salud
that
Universal,
in here
ofrece un
in the
análisis
world's
claro y oportuno sobre el
Health Day,
avance de
we're
la
able to give
atención
suitable
hacia la
opportunity in
salud
reference to the
universal.
progress
Se
towards
centra en
universal
tres
health,
indicadores clave.
which is focused on
Primero,
three main
la
indicators.
necesidad
The
de
first one is
satisfacción
the need
adicional del
of
paciente.
having satisfaction
Segundo,
of health
la
assistance. And
cobertura
second, the
de servicios
coverage
asistenciales
of these
desde el punto de vista
services
financiero.
and in reference to
Este
the
informe
financial
permite
end.
reconocer los
This is
logros
helps us to
alcanzados,
be able
así
to
como
see
qué señales
what we
de
have on the
mejora
time
aún.
to be able to see the
Hoy nos
challenges that we have
acompaña una
currently.
audiencia
Today
diversa
we have
de
an
responsables
audience
de políticas
that is
públicas,
direct to those that are
organizaciones de
responsible of
salud, investigadores,
health,
organizadores de la sociedad civil
researchers,
y socios internacionales.
investigators, and international
Son
aid.
varios los
We have many
participantes conectados que
participants
tenemos en
connected
este momento y les agradecemos a
that we have
todos.
today, and we truly
Este
appreciate for
momento
them being here,
proporcionarán
for their
fundamental
experience and their
transformar
knowledge is going
los
to be
hallazgos en
fundamental to be
informes,
able to
acciones
transform
concretas
the knowledge in concrete
y,
actions,
muy claras para
and
el
for them to be
desarrollo
able to be clear for
de
the
una salud más
development of
equitativa
the
basada en la atención
health
integral.
system
En
associated to the
Brasil,
region. In Brazil,
el Sistema Único de Salud garantiza atención
the
médica gratuita y
universal
universal
system of
de
health
infancia a
guarantees universal
calidad,
health in
confiable y
reference to different
proporcionada
levels and the
y participación
decentralization
social.
and
Esto
participation of
amplía
citizens.
significativamente el acceso a la salud
It is definitely
universal.
given
Sin
access
embargo,
to
también es
this
imposible reducir las
benefit
desigualdades
in
regionales
reference
sin
to being
ofrecer
able
los
to see the
resultados
regional
salud,
parts in reference to the
fortalecer la
results of health,
financiación
to be
primaria,
able to
aumentar
reinforce
la
primary
inversión
assistance,
pública
to
y atender
increase
mejor
public
los jóvenes
investment,
orígenes y
and
poblaciones
to
más
be able
marginadas.
to see all of
También es
the
fundamental contar con un
parts.
personal de salud
It
bien
is
capacitado,
fundamental to be able to have
distribuido
staff that
equitativamente
is
y con recursos
trained
adecuados
and
para
that have
responder a
suitable
las
conditions to
necesidades
be able to
cambiantes de nuestra
answer
comunidad.
to the needs that
Los
appear
objetivos de hoy
today.
de este panel,
The
de este
objectives of this
seminario
panel
son
today and of
dos,
the seminar
compartir y
are
explicar
to
conclusiones del
be able
informe
to
y
share the
fomentar
conclusion
soluciones
of the
prácticas
report
que
and to be able
determinen
to have
cómo
practical dialogue
va la salud universal en
that
nuestro
allows
país.
us to see how
Sabemos que muchas
universal health
personas
is
todavía
going and also to
tienen
be able to
barreras
see
para
here
acceder a servicios
what we
de
have
salud
in
de
reference
calidad.
to the barriers
Este
that do
informe
not allow us
demuestra
to be able
el
to
poder de
have
la cooperación
access to
entre los
this,
países que colaboran,
seeing that this is possible when
aprendiendo
have
y
collaboration among
pidiendo que la
countries,
sistema de atención
when we
primaria
are able to
fuerte nos
prioritize
acercan
a
cada vez más a
strong primary
garantizar
health
salud para todos y todas.
for
Gracias por su
everyone.
participación
Thank
en
you
este
very much for your
procedimiento para la
participation.
evaluación de gestionar
for your commitment towards the same aim that we have of universal health for all, to present the main findings of the report of the progress that we've had here, and also to be able to begin with this conversation. I would like to invite Dr. Ernesto Vascolo, who is also head of the Primary Assistance Unit and Integrated Services in reference to this part. It's a pleasure to give you the floor. Ernesto, please go ahead.
Gracias, Cristian.
Thank you very
Me
much,
confirman que
Christian.
se escucha bien, ¿no?
And if you can confirm you can hear me okay?
Bien,
Yes?
bueno,
Okay.
como bien decía,
Well,
como
as
bien
it
decía
was
Cristian,
said by Christian,
esta presentación
this
y
presentation
este reporte en
and
realidad
this report in
es un momento
reality
muy
is
importante
a
para
moment that
nuestra
is very
organización.
important for our
Es la primera
organization.
vez que en un
And
reporte
it is the
integramos
first
estas
time that in a
dimensiones
report
que
we're
son
able to
centrales
integrate the
para
dimensions which are
evaluar el desempeño de los
important
sistemas
to
de salud.
evaluate the development of the health
Quiero hacer
system.
esa mención
And
fundamentalmente
I want to
porque
mention this
si bien
fundamentally in
estamos
reference to the fact
acostumbrados en reportes a nivel
that although
global
we're used to getting
de
global reports
incorporar el
of the
análisis de
incorporation of the
cobertura
analysis of
y de
coverage
protección financiera,
and
en este
financial
caso
protection,
en
in
especial
this specific case,
vamos a estar incorporando no
we are going to be
solo
incorporating not
en
only
profundidad,
in depth with
con mayor detalle,
more
qué es lo que pasa en
detail
nuestra
what
región,
is happening
sino
in our
incorporando
region, but
una
also about
dimensión que de
incorporating
alguna
a
forma
dimension that in one way or the
caracteriza
other is
la
able to
agenda de salud
characterize
universal en
the
las Américas que tiene que ver
agenda of
con
universal
el
health
acceso.
that
Como
has to do
ustedes
with
saben,
access. As you well
la
know,
resolución allá aprobada
the
en el
resolution that
año
has been approved in the year
2014 en nuestra
2014
región pone
in
énfasis
our
no
region
solo
puts
en las
emphasis
condiciones de
not only in
cobertura,
the conditions
sino
of
también en el
coverage,
acceso a los
but
servicios
also
de
in the
salud.
access to health
No
services.
quiero
I do not
dejar de
want
mencionar
to forget
el
to mention
agradecimiento primero
the
al director de la
first
OPS,
my thanks and
quien
my
nos
appreciation to
motivó,
the director
¿no?
of
a hacer
uh,
este
the Pan
ejercicio,
American Health Organization
a
that
hacer este
motivated us to
esfuerzo de
carry out
trabajo
this
que
effort,
implica no solamente un abordaje
which
integral
implies not only an integrated
incorporando
approach
la cuestión
by
de acceso, como les
incorporating
comentaba
access,
previamente,
as we previously
sino
said,
dando
but it's
detalle.
also about
Perdón que te interrumpa.
Ernesto. I
¿Puedes
truly
poner la
apologize.
presentación en
Could you
modo
please put your
presentación, por
presentation
favor?
in presentation mode,
Opa,
please? Oh,
bueno.
sorry about that.
Mm,
No te vamos a descontar del tiempo estos minutos.
We are not going to be taking
tengo
any time from
problemas
you. Sorry, I have
para
issues.
hacerlo. A ver, vamos a intentarlo de nuevo.
Hold on, let
¿Ahora?
me try again. Is that okay now?
Ahí va.
Yes.
¿Se ve en forma completa?
Can you see it in the
Sí,
complete
ahí
screen?
está.
Ah,
Yes.
mucho.
Ernesto, y
Bueno,
disculpa
no,
la interrupción.
no hay
Adelante.
Apologies for
ningún
the
problema.
interruption. No, not a problem.
Bueno,
Okay.
como le
So,
comentaba
like I was
previamente,
previously
eh,
saying,
la, la iniciativa por parte del director fue clave. Esto lo estamos remitiendo hace
the
unos
initiative on behalf of the director is
en
key. We are going
general,
back some years ago. Here,
nuestra
in general,
organización,
our
obviamente
organization,
contribuíamos a un
obviously, it
reporte a nivel
contributes
global,
to a global
pero,
report,
pero
but
esta motivación por
this
parte del director
motivation on
a
behalf of
dar
the
un detalle
director to be
sobre
able to
cuáles
give a
son los
certain
avances y los
detail in reference
desafíos
to what are the
que tenía la
progress
región ha
and the
sido
challenges that
para
the region
nosotros
had
fundamental,
has
¿no?
been
Y en
fundamental
segundo
for
lugar,
us.
también
And
quiero
in second place, I also wanted
agradecer a
to
todo el equipo técnico
thank the whole
de la
technical
Unidad
team
de Atención Primaria de la Salud y Prestación Integrada de Servicios de
from the
Salud,
unit of this
especialmente
end,
el
especially
liderazgo también
the
que ha tenido
leadership that
Natalia
that
Houghton
Natalia
liderando el
Holton has
equipo
had
técnico
by
de
leading the
este reporte
technical
y de varios
team
reportes
from this
que hemos
report and
tenido y
different
que
reports that
vamos
we've
a
had
seguir
and
de
that we will
forma
continue in
sosteniendo
a
y
certain way
profundizando
sustaining
en esta misma
and
línea.
profounding
Quiero
on the same
empezar por el
line.
final, que son
I don't
los
want to
grandes
begin by the
mensajes.
end, which are
No quiero que
the
esto
great messages.
se
I
nos
do not
escape.
want
Son
for this
6
to
y
be
son
escape from our hands.
para mí
These are
sumamente
for us, it's
importantes, que
very
marcan la
important,
diferencia que tiene este
the ones
reporte.
that set the
En
difference.
primer lugar, el tema de acceso y las necesidades de
First
servicios
of
de
all, when talking
salud
about access and the needs
no
of health
satisfechas,
services that are not
es una de las
satisfied,
dimensiones que,
this is
si
one of the
bien ha estado
dimensions
en gran
that
parte
although
en
this
la
has been
narrativa, en los
greatly
discursos,
included in the narratives and the
muy pocas
speeches,
veces se generó un
a few
ejercicio
times it actually
de
generate an
medición sobre
exercise
estas
of
barreras,
measurement in reference to these
especialmente
barriers,
con una
and
mirada regional,
especially
incorporando un
with a
grupo de
regional
países.
perspective,
Hay un
incorporating a group
número
of countries.
que
There
nos
are
debe
a
atraer la
group of countries
atención,
that
que
should be
tiene que ver
attracting our
con que
attention.
una
That has to
tercera
do
parte de la
with a
población
third part of the
experimenta
population
anualmente como
experimenting
mínimo
on an annual basis.
barreras a acceder
Minimum
a los servicios de salud
barriers have access to health
cuando
service
los necesitan.
when you
Y
need them.
cuando me refiero a barreras de
When I
acceso, me
say
refiero
access barriers,
tanto a las financieras como
I mean
a las no
financial ones
financieras.
and also
En
non-financial
segundo
ones.
lugar,
Second of all,
bueno, uno de los indicadores
one of the
que hemos
indicators
estado
that we have been
sosteniendo y
sustaining
monitoreando a
and
través de los últimos
monitoring throughout
años,
the last years,
especialmente en el marco
especially
de
in
la
the
cobertura
framework of
universal
the
de estos reportes
universal
que
coverage
mencionaba
of these
previamente que la Organización Mundial de la
reports.
Salud lleva adelante. Lo que es importante para hacer un énfasis sobre estos
It's
resultados a
important to be able
nivel
to make
de
an emphasis
nuestra
in reference to
región
this resource at a
es
level of the
que este
region,
índice
which
de
is that this
cobertura
index
de servicios
of
de salud,
coverage
si bien
of
en
health
primera
services
década y
in the same
media
coverage in
de este
reference to
siglo experimentó
today to be
mejoras
able to
sustantivas,
experience
a partir
sustainable
del año
improvements
2019 se ha estancado y a partir
as of the year
incluso del
2019.
2021
It was
hemos
stuck, and even the year
encontrado
2021,
incluso cierta
we've
caída,
found a certain
desafíos
fall
que
in
son
reference to
necesarios
challenges that are
reconocer.
necessary
Acá
to be
quiero destacar
acknowledged. I do want to
incluso
highlight
desafíos
here and
particulares
even
en la
specific
cobertura
challenges in the
de
coverage
enfermedades
of
infecciosas.
infectious
Y gran parte
diseases.
de este desafío tiene que ver
A
con
great part of this
la,
challenge has to do with
la prioridad política que lleva adelante
the
la Organización
priority, the
Panamericana de la
political
Salud
priority
para
that
generar
is given
mejoras
in a PAHO to be
efectivas y
able to have a very effective,
muy
a
claras en
clear
términos de
results in reference
mejorar las
to
condiciones de
being
salud
able to improve
de
health
nuestra
conditions
población. En
of
tercer
our
lugar,
population. In
los
third place,
desafíos en términos
the
del
challenges in
financiamiento.
reference to
Esto
financing.
generalmente se mide en términos de
This
protección
basically is measured in
financiera
reference to
y la
financial
verdad es que
protection.
sigue
And the
siendo un
truth is that,
desafío muy
yes,
importante a pesar de
it continues
mejoras que
being
se han
an
generado
important
en
end,
las
although there have
últimas
been
décadas en
improvements
términos de
throughout the past
aumento del
decades in reference to the
financiamiento y
improvement of
especialmente del
financing and
financiamiento público.
especially of
Cuando
public
me refiero
financing.
a
When
estos
I
desafíos, tenemos
mean these
que
challenges,
considerar
I need to
que la
consider
población que
the
sufre de alguna
population
forma
that suffers in
gastos de
one way
salud
or another
catastróficos,
catastrophic
obviamente dependiendo
experience
de la
experiences in
metodología de
reference to, of course,
medición,
depending on the
pero
methodology
te
of
podría
measurement.
decir que
But
hasta
we
un
could say that
7,8% de
even
la
up to
población a nivel
7.8% of the
global,
population at a
cuando
global level,
utiliza los servicios
when
de
they
salud,
use
experimenta gastos
health
catastróficos.
services,
Y nos
they
estamos refiriendo a
experience
un número
catastrophic expenses.
sumamente
We are not
importante,
we're
¿no? Casi
talking about
80
an important
millones
number.
de personas experimentan este tipo de problema, pero
Almost
incluso
80 million people
aquellos
suffer this.
que no lo
But even
utilizan
though
por
those that
el
don't use
costo
it due to the
de ciertas
cost
prestaciones o
of such
medicamentos,
supplies or medication,
esto nos referimos al
this makes reference to
14,2% incluso de la población
14.2% of
que
the population,
no experimenta gastos
which does not
catastróficos porque no lo
experience any
utiliza
catastrophic
por el nivel
expenses
de
because
gasto
they
que
don't use
tiene.
it due to the level of
Pero
expense
por
that this
otro
has.
lado, una
But
de
on the other
las
hand, one
grandes,
of the largest
descubrimientos,
discoveries,
revelaciones
revealings,
importante
revelations,
información
or
que tenemos
important
que incorporar
information
en
that
la
we need to
mesa a
incorporate
la
in the
hora no solo
table
del análisis,
when
sino
not only
también de
carrying
poder
out the
intervenir
analysis, but to
sobre
be
la
able to have an
realidad, es
intervention
el
in the
peso que tienen las
reality,
barreras
is
no
the weight
financieras.
that
Y
the
con eso nos
non-financial barriers
referimos
have.
a
And
las
this makes reference
organizacionales,
to the
disponibilidad,
organizational ones and
aceptabilidad
to
o
be able to see
geográfica.
this part.
En este caso, este
And
grupo
in this
representa
end,
el
this
40%
represents the
de las
40%
barreras al acceso a los
in
servicios de
reference to
salud,
the barriers of
supera las barreras
access to
no
universal health
financieras a no
services. It
financieras
overcomes
en términos generales y es uno
financial barriers in
los
general.
puntos que
And these are
queremos
one of the
destacar
points that we do
y
want to highlight
resaltar
on
en el
in
reporte.
reference to
Todo
this
esto da
report.
lugar a la
Now,
necesidad de
another
tener
part of
un
this has to do with the
análisis
need of having
que
an
incorpore
integrated
las tres
analysis that
dimensiones,
incorporates the
que la
three
necesidad de
dimensions and
tener
also the need of
una
having
acción
an
urgente
action
que
that is
trabaje
urgent, that
sobre estos
actually works
problemas. Cuando
above
me
these issues.
refería
When we
a
talk
las
about the
necesidades
needs,
insatisfechas, necesidades de
the
acceso,
unsatisfied
es un
access
ejercicio que
barriers,
hemos
this is an
podido
exercise that
realizar
we have been
en
able to
7
develop
países
in
de la
17
región.
countries of the
El
region.
número más concreto es que el
The most concrete number
35,2%
is
de
that
la población
35.2% of the
no
population
accede en un determinado año, en
does
los
not
últimos años de la
accept
medición
in
de cada uno de los países por
the
alguna de las
past year of the
razones.
measurement of all
El
the
tema
countries
de
for one reason.
inequidades es un
The part
tema
of
muy
inequity is something
importante,
that is also
no
very
solo entre
important,
países,
not only
sino al
among
interior de
countries,
los
but also
países.
inside the
Y hay un
country.
hecho que es
And
clave,
here there
esta
is
dimensión es
that's a
una
fact that this
dimensión de
dimension is a
evaluación del
dimension
desempeño
of
de los
evaluation of the
servicios
performance
de
of
los sistemas de
services
salud
of the health systems.
que incluso se
And which
relaciona,
even
hay
is
una fuerte
related.
correlación
Here we have a
con la
high
mortalidad,
correlation with the
especialmente con la
mortality,
mortalidad
and
evitable.
especially with the avoidable mortality.
Incluso cuando
And even
analizamos las
when we
distintas barreras
analyze
al
the
acceso a los
different
servicios de salud, me
barriers to the
gustaría
access of
destacar
health
dos
services,
que
I
tienen que
would
ver
like to
con
highlight
los
two that have
organizacionales,
more
que
to do with the
lejos
organizational ones,
es en realidad
which
uno de los
acts is
desafíos
actually, in
más
fact, one of the
importantes a
most
la hora de
important
garantizar
challenges
acceso y el derecho a la salud. Y cuando
at the
me
moment of
refiero
guaranteeing
a
access
las
and access to
barreras
health.
organizacionales, ya no
But
nos
talking about the
referimos
organizational
solamente al
barriers,
primer
and we're
contacto,
not
sino a
longer
garantizar
talking
una
about only the same
continuidad de la
contact,
atención,
but
como
it's about
ustedes ven, es
guaranteeing
la más
quality of the
importante.
assistance.
Pero la
That's the most
segunda,
important
que es la
one. And the
financiera,
second one, which is a
si bien es
financial one,
menor, es la que
although it is
tiene
less, this is the
en
one
forma
that in a certain way or
mayor impacto
another
en
has
términos de
more of an
inequidades en
impact
la
in reference to
utilización de los servicios de
inequity in
salud.
the use of health
Cuando
services.
hablamos de
When we
cobertura
talk about
a servicios
coverage
esenciales, como
to
mencionaba
essential
previamente,
services, like I
si bien ha
previously
habido una
mentioned,
mejora hasta el
there has been
19
an
y un
improvement,
estancamiento,
and
quiero
the
destacar
19, I do want to
la
establish a
persistencia en
persistence
términos de brechas de
when
cobertura
talking about
entre
gaps
países y
coverage
a nivel de los
among
distintos grupos
countries
sociales al interior.
and the same
Cuando
social
nos
teams in
incorporamos sobre el
interior.
tema del análisis de
We
protección
incorporated
financiera,
the part
obviamente
of
la
analysis
primera
of financial
variable a
protection.
analizar se
The first
refiere
variable
al peso
makes
que tiene el
reference
gasto de bolsillo.
to the
Este es un
weight
tema que
that there
obviamente
is,
no solo
and they're
tiene
basically not only
relación
talking about
con
here what
el
is
modelo de
related
financiamiento y
to
la arquitectura
the
de los
financial
sistemas de
and the
salud,
architecture of the health
sino
systems,
también con el
as
peso que tienen ciertos
also
mercados,
with the
como es
weight
el
that
caso del
certain
medicamento, que
markets,
tiene
such
un
as
impacto muy
medication markets, that
importante
have a
sobre el
very
gasto de bolsillo.
large impact in
Incluso
reference to
cuando
this.
me refería
Even when
previamente
I made
al
reference to
gasto
specifically talking
catastrófico,
about the
es
catastrophic
importante
expense,
mencionar que hay
it's very
ciertos
important to
países
mention
con un
that there are
umbral
some
por
countries
encima
that
del
have a threshold
10%,
above
y de esa
10%.
forma nos tenemos
And
que
in
referir a gran
this
parte de los
way, we
países
need to
del
be able to
Caribe
see
y de
large part of the
Centroamérica,
countries
son los
and
desafíos
Central
más importantes
America,
que
which are the
tenemos en la
most
región.
important challenges that we have in the region.
Finalmente, en este
And
último
finally,
minuto, me
in this last
gustaría
minute, I
destacar
would like to
una de las
state
razones de ser
one
de
of the
todo este
reasons
reporte, que
of
tiene que
being of
ver
this whole
con
report, which has to do
ciertas lecciones en
with
términos de acciones de
certain
políticas hacia
actions
el
in reference to
futuro. En
actions of
primer
policies
lugar,
towards the
la
future.
necesidad de estar
First of all, the need
interpretando,
of being
la
interpreting
necesidad de
the
formular
need of
políticas,
formulating
iniciativas de atención
policies,
primaria de la salud
initiatives of primary
que estén
assistance for health
adaptadas a los contextos
that
particulares,
are
¿no? A los
adapted to
contextos de
specific
cada
contexts, to specific
territorio.
context of
Y
each
de esto
territory.
para
And in
nosotros
this
es
way, for
fundamental, no
us, this is
solamente por la
fundamental, not
perspectiva de
only due
atención
to the
primaria,
perspectives of
sino por la necesidad de
primary
evitar
attention, but because of the
la
need of
reproducción de
avoiding the
recetas y
reproduction
la
of
necesidad de partir sobre el análisis
starting on
particular
the
que
analysis,
tienen
specific analysis,
las barreras al acceso, la protección
the barriers to
financiera
access
y
financial
el conjunto de
protection,
actores que
and the
de
group of
alguna forma
factors that in one way or
intervienen,
another
participan en los
have had an
territorios
intervention and
a la hora de
participation in the
formular
territories
políticas.
when
El segundo
formulating
elemento
policies. The
clave
second
es la necesidad
key
de
element is
mejorar
the need of
la
improving
calidad de la
the
información y
quality
la
of the
disponibilidad
information
de
and
este
the
tipo de información.
availability
Este es el
of this
primer
kind of
reporte,
information. This is the first
simplemente es el
challenge.
primero.
It's
La
just the
idea
first
es no
one. The
solamente
idea
dar
is to not
continuidad
only give
con cada 2
continuity
años con
every
un
two
reporte con estas
years with
características,
a report of
sino
these
también
characteristics, but it's
profundizar en
also
los
about
países y al
working
interior de los
deeper on the
países
countries and inside the countries in
este análisis
reference to
integrado que
this
les
integrated
comenté
analysis
previamente.
that was being
Bueno,
mentioned
el
previously.
foco en el
Well,
contexto, el
they
foco
focus
sobre
on the
población en
context in
condiciones de
reference to
mayor
populations that
vulnerabilidad,
are in
la
higher
necesidad de estar
vulnerability. The
pensando cómo la
need of
atención primaria tiene
being able to see
sentido a
how
nivel
primary
subnacional
assistance makes
en
sense
intervenciones que
on
sean
this end with
efectivas.
interventions that are
Bueno,
quite effective.
ese,
Well,
estos son
That, in a way,
las principales
are
conclusiones.
the main
Muchas gracias,
conclusions. Thank
Cristian,
you very much,
y la verdad ha
Christian.
sido un placer.
And the truth is that this has been a pleasure. Thank you very much to you, Ernesto. Excellent presentation. I think that this is very much clear in reference to the discussion that is now continuing, to be able to see more specific aspects of what we have here and the implications for policy and tactics. It's a pleasure for us to be able to have these distinguished experts that are able to share their previous experience. So we have Adriano Mansud, Executive Secretary, Dr. James Mancia, a professor of policy and health management from the School of Public Health, and Dr. Rosen Navarro, technical officer from Financial Protection, Equity, and Poverty from the World Health Organization in Geneva. Thank you to each one of you for being with here today. To begin with, we have Dr. Matsua that is going to talk about the needs of the unsatisfied needs of health assistance and every adaptation to context. Unfortunately, Dr. Matsua is not able to be here in person with us due to agenda issues, last-minute agenda issues here in Brazil, but he's been kind enough to provide us a video with his intervention, and then we will show this video to you now. I would also like to say that we have 956 participants. Go ahead. Apologies for that. Go ahead.
Good morning. Once again, the Pan American Health Organization is encouraging us to critically assess the past in order to improve our public health systems based on evidence and on concrete experience. Thank you for inviting me to participate in this panel, and congratulations on the publication of Progress Toward Universal Health in America. This report draws on robust analytical material to develop strategic proposals and recommendations that will help our countries strengthen their health systems based on primary care. I would like to acknowledge and celebrate this valuable contribution and to convey the message that in Brazil we are working on all four of the report's proposed fronts. Brazil has one of the world's largest health systems, providing comprehensive care to over 200 million Brazilians, including vaccines, transplants, and free medicines. Strengthening primary health care is at the heart of our agenda. Although Brazil has built a broad and diverse network, we know that this alone is not enough. Our huge territory presents us with the challenge of providing infrastructure, care, and professionals across all areas. To address this, we are strengthening our staff with medical programs, investing heavily in expanding and improving call centers, and utilizing digital technologies. These measures save time and allow us to increase the quantity and quality of care provided. This brings me to my second point, which is the strengthening of our health system governance. Public resources are becoming increasingly limited, while life expectancy is rising and new, extremely expensive treatments are being introduced. So managing resources is more effectively becoming a key issue. Another area on which we are focusing is the requirement for a system of indicators as a monitoring and management tool. And the PAHO rapporteur confirms that we are on the right track. We are reviewing and updating all our systems and reorganizing them in an integrated manner with constant real-time monitoring. Good information has become an indispensable asset for all health managers. And to complete the picture, the fourth axis, also as identified in the report, which is within the scope of our actions, is the reduction of financial and organizational barriers with a focus on equity and the protection of the most vulnerable populations. The PAHO report confirmed in practice our perception that the COVID-19 pandemic has accentuated inequalities and deepened barriers to access to healthcare. These have been very difficult times, especially in Brazil, where unfortunately the government at that time weakened health policies and promoted enormous setbacks for our country. Now, President Lula's government is reviving structural actions and policies that are a model for the world, such as the STD/AIDS program, immunization program, transplantation, and family health strategy. With PAHO support, we are restoring Brazil's role and also innovating. And now I would like to leave a very important message. The health system must be based on primary health care, but that alone is not enough. We are facing a very important challenge posed by President Lula, which is the long wait for specialized care that is existent. There are consultations, tests, procedures, and treatments. We recently launched the Agora Tem Especialistas. Now there are specialists, freely translated program, which aims to mobilize public and private resources within the Brazilian healthcare system. The program's goal is to reduce waiting times for the Brazilian population to access diagnosis and treatment in essential areas such as cancer, cardiovascular diseases, ophthalmology, otorhinolaryngology, orthopedics, and women's health issues in a timely manner. We have invested heavily in improving the quality of information to enable us to allocate resources more effectively, mobilize budgetary and debt resources held by hospitals and health plan operators, and ensure that these debts are repaid in the form of health services rendered. In addition to strengthening our primary health care-based system, this is a fundamental key action to improve the quality of specialized care. This report highlights the importance of coordinated specialized care within health regions and networks, providing a basis for us to further strengthen a universal and comprehensive system that meets the health needs of the entire populations. Congratulations to PAHO on the report. We are always seeking to strengthen partnerships with other Latin American countries to exchange experiences and improve healthcare for our populations. Thank you very much.
Thank you very much, Dr. Masua, that is actually here at this time with the committee in reference to this part here, in reference to this part of the Ministry of Health in Brazil, with a very important initiative in reference to the health organization. We are now around 1,000 participants, 990 participants out of all the countries in Latin America, of the Americas, and an indicator from how this institution is working in reference to these countries. Now we invite, in reference to being able to share the experience of the alignments in reference to the power of indicators in the health sector. Please, James, go ahead.
Good morning, everybody. Thank you so much for this invitation. This is such an exciting event. As Dr. Morales pointed out, nearly 1,000 people from all around our region. It's really an honor and a privilege to be here. First, I want to also thank the organizers for the incredible work that they've put together with their report. I think trying to understand a complex concept such as universal health or universal health coverage is challenging. And I think one of the lessons we can learn from this report really is just how we've made a lot of progress. And now we're really honing in on those last miles in many places. And sometimes the last part of the journey really is the most challenging. What I'd like to do today, and this is, of course, what happens when you invite an academic to a presentation, I want to talk a little bit more about these specific measures of universal health coverage. I want to talk a little bit about how they work, how they're developed, how they're constructed, and what we can learn from them. I also want to talk a little bit about maybe ways that we can go a bit further with our data collection efforts to be able to really hone in on where we are having those problems in our countries and where we can really focus more resources. I really believe that primary healthcare is the fundamental basis for health systems around the world. But for that to happen, we understand that primary healthcare has to be accessible economically, geographically, and culturally. It has to develop long-term relationships with people and families, and this really requires trust and a long-term relationship. It needs to provide comprehensive care through multidisciplinary teams. And we know that this is definitely a challenge where we need to continue to develop a whole range of healthcare professionals to be able to form these teams. Primary healthcare also needs to coordinate care that's provided in other places, whether that's hospitals or specialists. It builds trusts and really needs to create links with communities and other sectors to tackle those social determinants of health that really are the fundamental causes of illness and inequalities. We know that most countries in the region also face challenges to meeting this goal of having primary healthcare serve as the fundamental basis of their health systems. We have fragmented and segmented health systems and health information systems. Often, care is poorly integrated or coordinated across these very different systems that define people very differently, perhaps based on where they work or what they've done. We often see weak links between primary healthcare and the communities that they serve for many reasons, including a really overtaxed health system that sometimes is really struggling to meet their basic needs. We often see, again, inadequate resources devoted to primary healthcare. I think that most countries have fallen short of the goal of 1% of their GDP dedicated to primary healthcare. I think that's a really important goal to keep our eyes on. And our information systems, while they are definitely getting better, they still have some weaknesses that prevent us from really finding where in the system we have problems so that then we can fix them. So the three indicators that were presented in the report, the universal health coverage, that is the proportion of the people in a country who receive a package of essential health services, catastrophic and impoverishing health expenditures, that's really how much it costs individuals to receive the care that they need, and how much do those expenditures affect the well-being of families. And finally, the newest indicator, unmet health needs, which pulls out and identifies specific barriers. So the specific things that are keeping people from getting the care that they need. While all of these indicators are really important, there are also things that they leave out. And I think that's also important for us to have a discussion about. So universal health coverage, although it's a very widely accepted and very well-developed indicator, it leaves out some things like ongoing care for some chronic conditions, mental health, cancer treatment, and surgery. It also leaves out the question of, was the care that you received adequate? Was it high quality? For catastrophic health expenditures, we know that sometimes people are unable to receive any care. Their expenditures would be considered zero, but we would miss them from this indicator. Also, people who receive healthcare, such as through the Brazilian SUS, who receive healthcare without any charge. That would also not be counted in this indicator, although we might want to know about people who have their healthcare needs met without having any expenditures associated with it. And finally, with this new indicator of unmet health needs, I want to spend a little bit more time talking about how it's constructed so we can understand its very important strengths, and maybe we can discuss some of the areas where it might be improved going forward. This is a picture that shows how this indicator was developed. I'll walk you through it. It seems complicated, but in fact, it's a very nice logical pattern. The indicator starts with asking someone if they had a recent illness or accident. If they did, then the next set of questions ask them, did you seek care for that problem? If they say yes, that's it. If no, then that's where we identify those healthcare barriers, right? Was it that you went and there weren't enough doctors, or the wait list was too long, or you weren't able to pay for the care that you needed? And this is a very helpful kind of a way of walking through the process of seeking care. A couple questions, though, also occur with this indicator. One, why are some people having an illness or accident and others are not? That relates again to the social determinants of health, and it's not necessarily as present in this indicator as we might like. The second question is, what about people who didn't have an illness or injury, but instead needed ongoing care for a chronic condition or needed to have a preventive exam? They would not necessarily be included in this indicator, and we might be missing some very important information about them. The final piece I think is pretty important is, although we ask people if they sought care, we don't know where they sought care. And so the barriers that we collect, those could apply to an emergency room. They could apply to a hospital. They could apply to a primary health care clinic. We wouldn't know in this indicator. So again, some of the details that we sacrifice to get an indicator that's easy to interpret, we also might miss some subtlety. So I want to walk you through an exercise I did using a Brazil public health data set to just understand what we're getting and what we might be missing with this indicator. So in this survey, it's a national survey in Brazil conducted in 2019, 88,000 people were interviewed. About 1 out of 5 of them looked for healthcare in the last 2 weeks. About 60% of them had an illness or injury. That's why they were looking for care. But almost 40% were looking for prevention or other types of care. Now, among both of these groups, almost everyone in this period was able to have their healthcare needs met, which is pretty remarkable. 3% were not met for those with a health problem, and 2% were not met for those who were looking for preventive care. These numbers are very high. These numbers are actually, in terms of receiving care, are very high. And I think that's something that is also really useful and important to understand here. The main reasons for not having your healthcare needs met for both people with illness and looking for preventive care were mostly due to waiting lists, waiting time, and the lack of health professionals. But one big difference occurs when you look at this a little bit more carefully, and I looked at some additional questions associated with these individuals. People having an illness or injury, they often would go to an urgent care or a public hospital. But people looking for preventive care, they most often would go to a public primary health care clinic. Very few of them would look to an urgent care or hospital care for preventive care. That's, again, a very good indicator. And the rate of seeking a hospital for those with an injury, as opposed to those looking for preventive care, was nearly 2.5 times higher. So it seems that this is pretty important information we might want to know if we want to use these indicators to go back inside our health systems to understand where the barriers are occurring and where we need to put additional resources and investigation to remove those barriers. For me, the indicators are very helpful, but sometimes it's a little bit like the 3 blindfolded men and the elephant, where each indicator is telling us only one part of the picture, and sometimes we risk missing the whole. So there's some ways I think these indicators could be enhanced and improved, made more usable. Some of them would just involve altering the way that the questions are developed, asking why people needed services, where they sought the services. And I think we really need to always keep in mind the importance of the voice of people. There are other ways to get patient-reported measures on the quality and experience that people had, as well as using qualitative and other data to really let people's voices speak so that decision makers can really hear what people are saying about the quality and experience that they have. Thank you so much.
Oh, thanks to you, Jane, for this very thoughtful presentation about how to understand unmet needs in healthcare. Continuamos con la intervención de la doctora Lavado, quien nos hablará sobre cómo
Moving on to Dr. Lavado's presentation, who will speak about financial barriers in healthcare access and the relevance to strengthen data to achieve effective monitoring of health systems. Come in, please, doctor.
Thank you very much. Good morning, everyone. My name is Rosella Vado. I'm with the WHO headquarters. Thank you very much for the opportunity to speak with you today. Am I sharing my screen?
Sorry, you are sharing it, but if you could put it on screen mode, it'll be much better. That's correct. Let me tell you that we have 32 countries right now and over 1,000 participants. Please go ahead, Russell.
Again, good morning to everyone, and thank you for the opportunity to speak today. I'm Rosella Vado from the World Health Organization, Department of Health Financing and Economics. This presentation is developed with Gabriela Flores on addressing financial barriers and strengthening data for effective health, primary health care, and universal health coverage monitoring. The focus of this presentation is twofold. Number one, to highlight the growing challenge of financial hardship in health in the Americas. And number two, to underline the critical role of strong, standardized, and disaggregated data in enabling effective policy action. Let me start my presentation with why financial protection matters. In the Americas, the data are concerning. 7.8% of people experience catastrophic health spending. This is where health costs exceed 10% of the household's budget. 14.5% are pushed or further pushed into relative poverty due to out-of-pocket health expenses. And 14.2% report having foregone care entirely because of financial barriers. These statistics highlight two forms of financial hardship. First is catastrophic health expenditures, which indicates economic stress from large and unaffordable payments. The second is impoverishing health spending, where people cross or fall deeper below the poverty line after paying for care. Whether it's foregoing care, catastrophic, or impoverishing spending, any form of financial hardship points to insufficient financial protection. These are signals of system failure. When health systems fail to provide accessible, affordable care, people are forced to make unacceptable trade-offs between their health and their basic needs. What's more, these burdens fall disproportionately on the poor. Health financing systems that rely heavily on out-of-pocket payments reinforce inequity rather than protect against it. This not only undermines equity, but reverses progress towards universal health coverage. As we'll explore, understanding and tracking these financial barriers through better data is essential to strengthening PHC and advancing UHC. This brings us to the crucial link between financial protection and unmet health needs. Unmet needs refer to situations where individuals require health care but do not receive it. In the Americas, financial reasons are the second leading cause of unmet care needs, reported by 14.2%, just after organizational barriers at 21.5%. This is a strong indicator of access barriers, often invisible in traditional expenditure statistics. Here is the issue. If someone is too poor to seek care, they don't spend any money. So financial hardship is hidden. This leads to underestimation of the true burden on vulnerable population. What is more troubling is that the poor are more likely to experience these unmet needs. They live in a state of silent exclusion, not only at risk of catastrophic spending when they do access care, but also excluded when they avoid care altogether. This underscores why financial protection should not be narrowly defined by expenditure thresholds alone. Instead, it must reflect a broader concern with removing financial barriers to access and ensuring equity in health system use. Therefore, a robust financial protection framework must capture both financial hardship and foregone care, recognize that no care is not always good news, and provide tools to monitor these effects among disadvantaged groups. Despite these known challenges, our ability to act is severely limited by gaps in data. There are three main issues. First issue is availability. Many countries do not routinely collect or publish the necessary data to monitor financial protection, especially data on unmet needs. But in most countries in the Americas that are collecting data, it is publicly available. Second is disaggregation. Where data exists, it is often difficult to disaggregate by income, gender, age, ethnicity, or geography, making it hard to understand who is the most affected. For example, as shown in the report, it is not yet possible to compare unmet needs, service coverage, and financial hardship for the same vulnerable group or region within a country. Third is the lack of standardization. Countries use different methodologies and indicators, preventing regional or global comparability. In essence, we are trying to solve a problem we can't fully see. This limits our capacity to identify the vulnerable groups, monitor progress over time, and design or adjust policies based on evidence. If we want policy to be evidence-based, we must first strengthen the evidence base itself. And that means closing the data gap with better surveys, consistent standards, and more regular reporting. This is a global challenge. And yet, the region of the Americas is leading by example, showing that valuable insight is possible even with imperfect data. Because, as we often say, we cannot fix what we cannot measure, but we also cannot wait for perfect data to act. So how do we build better systems for monitoring PHC and UHC, especially financial protection? We recommend 4 strategic actions. First, invest in integrated routine data collection. This means household surveys that are frequent, nationally representative, and designed to measure all dimensions of coverage, including utilization, unmet need, and financial hardship. Number 2, improve survey instruments. Many surveys fail to ask the right questions about unmet needs, barriers to care, or coping mechanisms. We need to adopt tools to reflect people's real experiences and to ensure these are captured at both national and subnational levels. Number 3, promote standardized methods. We need to use comparable indicators and harmonize definitions across time and across countries. This will help us benchmark progress and conduct meaningful analysis of trends. The region of the Americas is actively contributing to a WHO working group on the measurement of unmet need and barriers to effective service coverage, created in response to a member state's resolution. This work is exploring the feasibility of adopting unmet need as an additional UHC monitoring indicator. And lastly, we need to foster data interoperability. We need to link data from different sectors such as health, social protection, and finance to build a fuller picture of risk and resilience. This kind of integration enables governments to target support and evaluate impact more effectively. Strengthening monitoring is not just a technical task, it is a political commitment to accountability and inclusiveness towards evidence-based policymaking. Let me end with 5 key takeaways that summarize both the challenge and the way forward. First, financial hardship is real and growing in the Americas, especially for the poor and marginalized. It's not just about cost, it's about access, dignity, and justice. Second, monitoring unmet needs together with financial protection is essential. One without the other leads to blind spots. Together, they give us a clearer picture of health system equity and performance. Third, stronger data enables smarter policies. Without timely, disaggregated, and standardized data, we are blind to the deficiencies of the system. Investments in data systems must be prioritized as foundational to UHC reforms. Fourth, peer learning matters. Countries in the region can and should learn from each other's experiences in designing surveys, using indicators, and building governance for data systems. And lastly, we need to use evidence to act. Data are only powerful when they inform decisions on budgets, benefits, and service delivery. Governments must use financial protection data to align policies with equity goals. Ultimately, protecting people from financial consequences of ill health is both a moral imperative and a practical strategy for building resilient, inclusive health systems. Thank you very much for your attention. If you have any questions, please do not hesitate to email us through fprotectionstats@who.int. Thank you very much.
It seems that I lost a little bit my connection, but I'm back. Ahora pasar a la sección de preguntas y respuestas.
Now moving on to our Q&A section, we have gathered your questions via the chat, and we selected some to share with our panelists. Every panelist, apologies, this is a note from your interpreter. Our connection with our speaker is not very good at this time.
Perdón,
Por favor, el mismo orden en que presentaron, vayan
In the same order in which they presented, they can answer. Participants via the chat have proposed many concerns on non-financial barriers to access, including the increase of waiting lists, which is affecting the reality and elevating mortality in general. Also mentioned specific challenges that the population is facing in vulnerable situations, such as disabled individuals. Also, it highlights that the acceptability, apologies, our audio is interrupted again.
Perdón, Cristian, creo que... Sí, Cristian, perdón, pero se ha
Christian,
cortado un poco.
apologies,
Creo que has
but
tenido un problema de
your
conexión.
feed
No
is
sé si
cutting in and out. I believe you're having
podrías
connectivity
recuperar.
issues.
Ahí sí.
Can you
Ahí te
hear
escuchamos, sí.
me? No.
Bueno,
So I don't know what part I lost connection at, but the questions we have via the chat for each of our participants. You can answer in the same order in which you presented. The first is for you, Ernesto. And it relates to how we can reformulate our policies to tackle all access barriers beyond
Bien,
financial barriers. For James on the chat, many participants are asking how indicators on barriers in primary health are compiled, including areas such as mental health. It is suggested for participation mechanisms. Sorry, it's cutting out again. Citizen participation can help to supply the lack of information on lived experiences and community health services. Also, a question on certain indicators, how they're measured via surveys and with what frequency they should happen and improve to know the situation. The specific question, James, is how the combination of indicators can foster better collaboration between disciplines and sectors in the assessment and improvement of healthcare systems and primary health attention. Finally, for Dr. Lavado, the chat and in your presentation, it highlights the need to improve data and interpretation of data on financial protection and economic barriers, as well as efforts on alternative means to measure catastrophic out-of-pocket expenditure. The audio cut out again. To benefit environments with less resources and to accelerate progress toward universal health coverage. So, with those three questions for each of our panelists, we will now begin this section of the seminar. Ernesto, please.
Gracias. Gracias, Cristian.
Thank you, Christian. It is a question that is on me to answer. It is highly interesting in terms of, I can summarize when we discuss how we can tackle differently the non-financial barriers. I'm being asked not only the what, but the how for calling it so. So answering to non-financial barriers in many cases, obviously considering the features of the context, is asking us about the model of attention and how not only healthcare services are organized, but the set of resources and interventions in health in a certain territory. And when I say the how, I mean not only how we are distributing services, resources, professionals, but how at the same time they are coordinating amongst themselves. Most part, when non-financial barriers and especially the organizational ones are important, and in some countries such as Brazil that Adriano mentioned, but also in Chile and so many others, we refer to, at the same time, the presence of waiting lists, very important, as an outcome and partly as a consequence not only of what was COVID, but the need to tackle the complexity of services with populations where it is not only the out-of-pocket expense, but also their social determinants, their cultural elements, and to what measure the organization of the service network can facilitate a more integrated process which guarantees continuity, which allows to adapt not only needs but also perceptions and health conceptions by the population, again, in each of the territories. Therefore, the how entails greater capacity for interpretation on what is an issue and the conditions of health in the population and the resources that we have in a certain territory. This implies making reality a primary health perspective. This implies going beyond the first level of attention, and that implies an exercise where health policies based on primary care need to be grounded with governance structures at the subnational level and in each of the contexts. Well, that is somehow a very provocative question and very interesting question, which I would say mostly goes through technical cooperation that PAHO has and the involvement and lines of work that most countries in the region have. Thank
Muchas gracias, Ernesto. James, si pudieras abordar tu pregunta, por favor.
Thank you very much, Ernesto. James, if you can
Thank
please
you.
approach
I
your
think there were
question.
a couple different parts of questions. I can take a couple pieces of them. I think for me, it's very exciting to see how interested people are in really getting involved in the indicators and understanding what they mean. I think that's the most important first step. We really need to understand what these indicators are telling us, and then we really need to make sure that we use what we learn from them in practice. I think there are many ways to collect information about specific barriers. One of the strengths of these indicators is that they all come from household surveys. So within those surveys, there are many other kinds of analyses that can be done. I think one of the difficulties is that often we rely on a data analyst to do this for us. And one thing we might think about is, are there ways to use new technologies, whether it's AI or other approaches, so that individuals can go and get questions from some of these nationally collected data? I think that would be an incredibly empowering approach. I don't have the technical solution to do that, but I believe it's within our reach, and that might be something for us to consider in the future. There were also questions about the can we believe in the data that are collected? And I think that must have come from another scientist, because we are always skeptical of the kind of data that we collect. But I think Dr. Lovato talked a lot about how we can be more confident in the data that we collect, and that's by using standardized instruments, things that have been tested in many different situations and contexts, and that are collected in an objective way. So if you're looking at data and there isn't a description of how they were collected, then I think you're right to be skeptical about the quality of those data. So always look to make sure that the data that you're using really come from a reputable source and one that is representative of the area you're looking at, right? So you don't want to use data on Brazil to talk about Argentina. That would be a big mistake for many reasons, as we can all imagine. Finally, the last question is about how this combination of indicators, right, looking at the different parts of the elephant, can bring us together. And I think that's a fantastic question. Clearly, we must have health professionals involved in this. They're the ones who are going to tell us what are the parts of the health system that need to be examined closely from their perspective. We also need people from economics or healthcare finance, because a lot of the barriers we've seen are financial, and those financial barriers have implications not only for people's healthcare, but for well-being and overall economic growth of a country. I think we also really need to incorporate individuals. One of the questions asked about whether mechanisms for popular participation would be an important component here. Absolutely. I believe that when countries come up with reports about the quality or barriers in the health system, a part of that should really be interviews or discussions with individuals, with citizen groups and others who have a real stake in this, and also provide their opinion and their advice on where the health system should go next. Thank you.
Thanks to you, James. And now we go to Dr. Lavado. Please go ahead.
Thank you very much. This is a very interesting discussion. The question that was asked to me is how lessons learned from countries with strong data systems can be adopted to benefit resource-constrained settings and accelerate progress towards universal health coverage. Indeed, as was highlighted during my presentation and in the response of James and Ernesto, it's very difficult to collect data for this because this is usually a huge endeavor. This is a household budget survey, particularly for the data needed for financial protection. The Americas is lucky because most of its surveys is actually originating from living standards measurement surveys. And that allows you not only to be able to estimate financial hardship, financial protection indicators, but there's also usually another module that allows you to look at barriers to care through that individual module as well as foregone care. So in this regard, the Americas is very lucky that most of the established surveys are like this. Now, depending indeed on the country's capacity to pay for these surveys, some countries do it more frequently than others. Luckily, in this day and age, there are many technological advances that we can do to supplement these big household surveys that are done every 3 years, every 5 years, or in some countries every 10 years. In between, we have been looking at the possibility of supplementing this information with mobile phone surveys, for example, because this is a cheaper way of collecting data through the phone. And during the time of COVID, there was also an opportunity to see how surveys collected through Facebook, for example, can be used to supplement information on foregone care and unmet need. We have been working to see whether these are, approximating the surveys, and initial evidence shows that give or take, they do. Possibly a good proxy for this. So what we are saying is for those interim, the big household surveys, we could possibly supplement data collection with other methods of collecting. And this will give the policymaker an interim picture of how the progress looks like.
Thank you very much for those insights. We have time for a second round of questions. Y me gustaría, antes de hacerle la segunda pregunta,
Before I pass it on to the second question, I would like to invite the panelists to interact in the Q&A where there are questions that maybe because of lack of time we're not going to be able to solve here. So the first question that I have here in the second round for Ernesto, the report states that the reinforcing of primary health assistance is essential for a universal health that is sustainable. How are the countries able to put into operation this focus in territory that is able to see the diversity and the needs and the context of health within the countries? We also have one for James. What opportunities does this integrated framework offer to be able to adapt the measurement tools to the emerging health priorities and the different needs of the population? And finally, for Rosel, how can we have a detailed information of the financial barriers based on more accurate information help to interact in reference to this and of the diverse communities? 2-3 minutes each one, please, tops, to answer your question. Thank you. We can start with Ernesto. Thank you, Christian. Well, the question, in a certain way or another, is oriented towards the same direction of the answer that I made initially. But this allows me to be able to expand this fundamentally in the need of reinforcing capacities of governance of the health authorities. This, in a certain way, is able to carry out a strategy that allows the recognition of the diversity and the needs in the different contexts. A country requires not only policies and resources, but
involucrar
it
actores
also needs to involve fundamental actors
la palabra me parece clave
as
tiene que ver
this part
con garantizar una acción colectiva.
to be able to guarantee a collective
Involucrar
action.
no solamente funcionarios y la estructura técnica de los ministerios
The
de salud a
technical
nivel
structure
nacional,
of the
sino
ministries of
también
health in a
a
national
nivel
manner
subnacional,
and also in a
y otros
subnational
actores
and
interesados
also
y
other
involucrados en una
actors
iniciativa con estas
involved in an
características.
initiative
En ese
with these
marco, creo
characteristics.
que el rol que tienen los recursos
The
humanos es
role that
fundamental.
human resources have is
Realmente
fundamental
vinculamos el tema de recursos humanos como un recurso
in reference to being able
más
to
y no
see this
como un
part
sujeto
in reference to
indispensable, ¿no?
something
Para
that is important,
acercarse a la población,
to being
para
able
repensar la
to
forma
start thinking about
de
the
darle
way
respuesta en los servicios de
and
salud a
giving
las necesidades de la
response in
población.
reference to the need
Y
of
por
the
último, quiero
population.
poner énfasis sobre las organizaciones
I mean, to
sociales,
make emphasis on social
todos
organizations
aquellos actores que tienen
in
cierto
reference to these
compromiso
actors to have some
directamente
kind of
porque
commitment
o son
and
parte de agrupaciones de pacientes
they are
o
parts
porque
of the
son actores
patient or because they are
políticos
political
muy
actors
involucrados en
that are
garantizar el
involved
derecho a la
in
salud por
reference to
parte de
being
la
able to
población. Yo
guarantee
creo que
this
hay
to the
un
health and part of the
elemento que tiene que ver con
population.
la
I think there's
gobernanza,
an element that
que
has to
tiene
do
que
with
ver no
governance
solamente con el componente
and
institucional, sino también
it's
político, que
seeing this
requiere
also
que
on
las
the end that
políticas se
guarantees
transformen
these policies to be able to
en
transform
procesos
into
sociales que
processes and
aterricen
social
en los
processes
territorios.
that land on
Bueno,
the countries.
gracias, Cristian.
Thank you, Christian.
Muchas gracias, Ernesto. Hay algunos comentarios que dicen que no se escuchan. No sé si yo estoy
Sorry,
escuchando bien,
there are
pero a
some
lo
comments that
mejor
are
hay algo
establishing that
técnico
people
que
cannot hear us. Maybe there's something technical that you can help me on
está incidiendo
or
ahí
that
para
can
que
be
se
happening
considere
here
en
so you can
este.
take this into
James, por
consideration.
favor,
James, go ahead with your
respuesta
answer,
adelante.
please.
Adelante.
Thank you. I think these are really important questions, and understanding what we learn from these indicators really, I think, can be an opportunity. But we have to understand, and one of my mentors always said, data are just a shadow of what's happening in real life. So they don't give us the full picture. No matter how perfect our measures are, they only are pieces of a map. We need to have that kind of GPS system, and that system really is the governance structure, right? So having the data without having this larger structure that's going to analyze and take action, I think, again, doesn't provide these kinds of opportunities that we might like. So I think that reports like this and these kinds of measures are excellent ways to kind of stimulate and promote that discussion at national level. The more the information gets out and the more people feel empowered to ask questions and to understand, well, in my city, it's a little bit different. That kind of feedback, I think, is really the next step. And that really foments a national discussion, a discussion that allows us to make sense of the indicators, but to put them on a roadmap so that the objectives for the nation are obtained. And too often, at least in my field, we end with, we have validated the indicator and that's it. And I think that's insufficient. So I also call on other people working in this field, really in the measurement field, to really take the next step, incorporate citizens, policymakers, and others into the process so that they understand and trust the measures and can use them to develop that roadmap. Thank you.
Thanks to you. Dr. Russell.
Yes, the question that was asked to me is about disaggregation, and that is a very good question. Indeed, the report gives us a picture at the national level, but as James was saying, after we get it from the national level, we need to go beyond to be able to translate it into actual policies in our country. So we encourage MOH to go beyond the national figure and really look at the disaggregation of data. So there are various disaggregations that are available already in the monitoring framework, such as types of households, the age, the economic quintile. But beyond that, we can go, you can decompose it by regions or by municipalities or provinces, especially if the country you are in is decentralized, for example. So with decentralization, most of the decisions are made at the local level. So there is really benefit in disaggregating the national figure by your locality, especially if the data allows. Luckily, many data sets in the in Latin America and the Americas allows you to do this kind of disaggregation, and that would allow the government to prioritize which areas they can go to, and also compare each area and see which are performing well and those that are lagging behind, and allow them to work towards each other, to learn from each other, so that those that are ahead of UHC and PHC indicators can transfer the learning to those that are kind of far behind. So we highly encourage everyone to utilize the data and disaggregate it. Thank you.
Bueno, muchísimas gracias y quiero felicitar a todos los
Thank you very much.
panelistas
And I would
por
like to thank all of the panelists for the
que han
great amount of
seguido
discipline that they have had
lo que
by
nos
always
permite
maintaining
dar
themselves
esta
within time,
oportunidad
which
de
allows us to
hacer
be
un
able to
último
give the
comentario
opportunity of
de
having
1 o
one
2
last
minutos
comment, or maybe
máximo
1 or 2 minutes
para cerrar
maximum,
en
so
términos
we can close
de sus
in
intervenciones.
reference to your
Ernesto, si hay
interventions.
algún
So,
mensaje que
Ernesto,
quisieras
if there is any
compartir
message that you would like to
con nosotros,
share
adelante.
with us, go right
Bueno, muchas
ahead.
gracias y la verdad
Well, thank you
que
very much. And the
felicito,
truth
Cristian,
is
porque esto
that
nos
I
pasa muy
truly
pocas veces,
congratulate
digamos,
you,
¿no?
Christian, because this
Que
really does not
haya el
happen
tiempo
many times,
suficiente
that
para
we
que
have
esto
actually
arranque.
enough time for so many
Yo
rounds
quiero
of comments.
aprovechar este
This rarely
momento
happens. But I do want to
para
take
destacar
this moment to
la
be
agenda de
able to
trabajo,
highlight the
¿no?
agenda, the
Quiero
work
resaltar que
agenda.
este
I want to
es un primer
establish that
reporte,
this is the first
pero
report,
no solo vamos a
but
repetirlo
we are
cada
not
2
only going to
años,
be repeating this every
sino
two
también
years, but we
dos
are
cosas quiero
also,
destacar. Por
we
un
want
lado,
to establish
estamos
here two things. On
trabajando
one
en
end, we are
una
working
encuesta sobre el sistema
on
de
a
salud
survey in
básicamente
reference to the
en
health
los
system
países con
based
una
on the
información sumamente
countries with
complementaria
organization that is just complementary
a este reporte que nos
to this
permite
report, which allows us
reconocer
to
con
be
mayor
able to
profundidad aspectos
recognize
que
with
tienen que ver
more
con
depth
recursos
aspects that have
humanos,
to do with human
financiamiento,
resources,
gobernanza y modelo
financing,
de atención
governance, the
que
model
yo
of attention
mencionaba.
that
Así que
we
muy
are mentioning.
probablemente
So it
tendremos
is
un reporte el año
possibly
que
it's
viene
possible that we have a
con
report next year
combinación no
with
solamente de
the
resultados,
combination of
sino
not
de
only
cómo
of
está
results,
estructurado
but how
los
we have
sistemas en
this whole
nuestra región.
structure in reference
Y
to the
por otro
systems in our
lado,
region. And
quiero
on the other
destacar
hand,
que
I do
esto
want to
es un
establish
primer
that this
paso
is a first step
motivando que no
to
solamente tengamos
motivate the
más
fact that we
países
not
con
only have more
información
countries with
suficiente dentro de 2
information,
años,
enough
sino que
information in 2 years, but
profundicemos
that we
este
are able
tipo
to
de ejercicios
work
en los
deeply on these
países,
kind of
¿no? Una
exercises in the
parte,
countries.
como la doctora
The
Lavado y
majority,
James
like Dr. Lavado
planteaba
and James
previamente,
have
este es
said previously,
un análisis
this
crítico
is an
fundamental, no
analysis that
solamente
is
para
critical,
saber
fundamentally
cuáles son los
speaking,
desafíos,
not
sino
to
para
only know
estar
what are the
elaborando
challenges, but also
políticas.
to be
Así que bueno,
preparing
muchísimas
policies.
gracias.
So yes, thank you very
Okay,
much
muchas
for
gracias,
that.
Ernesto.
Thank you very
James,
much,
last comment.
Ernesto. James, last comment?
Thank you. I want to say, most importantly, that one of the challenges of doing this work, of understanding the progress in health systems and services, is that I'm sorry to tell you, we will never be finished with this process because a good health system is organic. It grows and changes according to people's needs. And we know that people's needs are changing today as our planet changes and other things change. So we need to do more of this. We won't, I think, reach a point where we have the perfect indicators and we're done. Instead, I think the mark of success is using those indicators to make concrete changes today. Thank you.
Thanks to you, James. And Dr. Lavado, please, your last thought.
Thank you very much. And I think I would just like to echo what my colleagues have said earlier. Monitoring data will be useless if we don't translate them into policies. So I highly encourage everyone to let us utilize this data. Let us use all these efforts in monitoring to be able to make some changes in our health systems so that we can pursue universal health coverage and EHC. Thank you.
Muchas gracias. Thank you very much, Dr. Lavado. Y gracias a todos por sus
And thank you very much to everyone for your comments, to the panelists, and to also the over 1,000 participants that we have here from different countries, including Guyana and France, from the region of the Americas. Before passing on to the conclusions and the closing of this event, we do want to remind you that the recording of the event and also the presentations and materials will all be in the website of the same event, and we are going to be sharing this with you through a link in the chat. Now, to finish this discussion, I would like to give the word to another James, Dr. James Fitzgerald, Director of the Department of Systems and Health Services of WHO and the
Thank you very much,
PAHO.
Christian. Muchas gracias por todo. Really, and thanks to all really who have joined us today for this high level of engagement that we've seen around this important discussion. It's really been a privilege to listen to you, to share the space with such a diverse and committed group of experts and professionals from around the Americas and well beyond, who are working towards this shared goal of universal health. A special thanks to Dr. Adriano Massudo, who's the Executive Secretary of the Brazilian Ministry of Health, to Dr. James Jacinco, the Professor of Health Policy and Management at UCLA and the Fielding School of Public Health, and of course to our dear colleague in Geneva, Dr. Rosel Lavado, who is a Technical Officer in Financial Protection, Equity and Poverty. And a special thanks to you, Christian, for excellent moderation of this event. And for facilitating the dialogue between the panelists while monitoring also a very engaging level of chat we've seen. We've really heard and received some valuable insight and heard the evidence from our expert speakers today. And I think I really want to build on this fact that we are reminded of the real everyday challenges that people across the Americas continue to face in ensuring access to healthcare and addressing both the financial barriers within the respective health systems. The report on universal health in the Americas that we launched last December really provides us with a very clear understanding of where the gaps lie within our health systems in the Americas, not just a snapshot, but a more comprehensive analysis through the combination of these three indicators, looking at unmet healthcare needs, the coverage of essential services and financial protection. It's really this multidimensional analysis that provides us with a more complete view of the barriers to access. And it's not really just about barriers to access of health services per se, but health in general. It's about systems, about services, and we heard also it's about addressing the social determinants of health through the primary healthcare approach. And such an integrated measurement approach really allows us to better target thereafter the specific interventions that have to be developed, population-focused, individual-focused, territorial-focused, prioritizing investments and tracking progress over time. Three little reminders for us as we move forward. First of all, this data should guide policy development, strategic planning processes at the national and subnational level. Our systems must be built to listen to the data, to listen to people and the communities that they serve. And this includes really addressing issues associated with the cultural and linguistic responsiveness of health systems and addressing the differentiated needs of people in rural and remote areas. And then aligning resources, of course, with that. Secondly, building on that issue of resources, we must continue to strive for increased and improved investment in primary health care, not just because it's cost effective, we know it's cost effective, but it really produces and generates the health outcomes that we seek to have and improve health throughout the life course of peoples in the Americas. This really means that we need to strengthen investments in the first level of care, reaching out to communities, to people, strengthening integrated care, strengthening integrated health service delivery, and ensuring that our systems are more resilient to health crisis. And finally, to really focus on that issue that I think has been central to the discussion, improving the availability, quality, and use of data to inform decision-making and policy design. We need to continue really to develop robust health information systems that facilitate the collection of disaggregated data and linking thereafter with more population-based studies to guide our policy development over the future. So we at the Pan American Health Organization really remain fully committed to supporting our member states in turning these findings into meaningful action in accordance with your individual context. Our report is available on our website, We've shared it in the chat. We really encourage you to delve more deeply into the analysis, to look at your data, the data that is relevant to your country, to your territories, to your institutions and communities. And we'll continue as an organization in the coming months to organize more technical activities, more webinars to delve more deeply into some aspects of this dialogue and to look at shared practices as we deepen our technical cooperation across the region. So thank you very much, Christian, once again. Thank you to everyone here today. We wish you all a really wonderful day, afternoon, evening, wherever you are throughout the world. Many thanks.
Muchas gracias a ti, James, y muchas gracias también a todos por conectarse y participar en este seminario virtual.
Thank you very much, James. Thank you very much to everyone for connecting and participating. I do want to ask each one of you to please approach the PAHO offices in your countries. That is where we can start building a movement that is more solid and richer, that is going to allow us to help everything in reference to health, to be able to aim towards universal health, universal access to health in the Americas. Thank you very much. You all have a very nice day.
Chao.